Hello, my name is Dr. Michael Jaff. I'm a vascular medicine specialist, and I'm the Chief Medical Officer for the Peripheral Interventions Division of Boston Scientific. And Boston Scientific is incredibly proud to sponsor this important panel discussion on the impact of peripheral artery disease of the leg on the Black community. We've got three major goals for this session today. One, we want to sound the alarm. You need to know how important peripheral artery disease is to the general population and, more importantly, to the Black population. Number two, we are going to encourage strong action. We need advocacy, we need legislation, we need policy change in order to save limbs and save lives. And then finally, we are going to stop this rash of amputations among this underserved population. I am joined by an amazing panel of experts in this field. I'm going to spend a moment just introducing them and then bring them to you. First, an honor to be working with Shamika Hawkins-Taylor, PhD. Dr. Hawkins-Taylor is a faculty member at Xavier University in Louisiana. She's a PhD from the University of Minnesota College of Pharmacy. She received her master's and bachelor degrees from the University of Southern California and University of California, Davis, respectively. You can see what a superstar Dr. Hawkins-Taylor is. Most notably, it is really interesting to note that Dr. Hawkins-Taylor has focused her research recently on the social impact of unmanaged diabetes and the impact of housing arrangements on the quality of life of elderly Black populations. This is going to be a topic we are going to come back to. Second, my colleague, Dr. Felucio Faccariti. Dr. Faccariti is an interventional cardiologist who attended college at Rutgers University. His medical degree from University of Medicine and Dentistry in New Jersey, Robert Wood Johnson Medical School in Camden, New Jersey. Did an internship and residency in internal medicine at New York Presbyterian Weill Cornell Medical Center in New York City, and then completed a fellowship in cardiology, interventional cardiology, and endovascular interventions at Cooper University Hospital in Camden, New Jersey. Dr. Faccariti works in central Mississippi and started Cardiovascular Solutions, has focused his career on this population of patients. Dr. Faccariti, great to be working with you on this. And then finally, my colleague, Dr. Paul Michael. Dr. Michael is a native of Miami, Florida, earned his doctorate degree at the University of Miami School of Medicine. He then completed an internal medicine residency at the Cleveland Clinic, Florida, as chief resident, and continued his studies in cardiovascular medicine and interventional cardiology, as well as being chief fellow at the Ochsner Clinic Foundation in New Orleans, Louisiana. Dr. Michael's board certified in internal medicine, cardiovascular medicine, and interventional cardiology, and has focused his career to fight critical limb ischemia, that is the most advanced manifestations of peripheral artery disease. Dr. Michael, great to have you with us. I'd like to start off by just asking our panelists very quickly, 1 minute, if by the end of this discussion, you could have one message that you want this audience to remember and take away, what would that be? Let's start with Dr. Hawkins-Taylor.
One message I would share and hope that is remembered is that losing a limb is not just about the physical and biological implications. It's really about the social implications. It's about the life and longevity of the human being that has lost a limb and how the trajectory of the life has changed.
Dr. Faccariti, what's the message that you want this audience to understand?
Of all forms of inequality, injustice in healthcare is the most shocking and most inhumane. And that was a statement by Dr. Martin Luther King that was stated in 1966. That still remains true today when it comes to the unnecessary and preventable rates of amputation in low socioeconomic communities and in racial and ethnic minority groups that are disproportionately affected with PAD. PAD is the most costly, deadly, debilitating, and most prevalent diseases that most Americans have never heard of. And I hope that we raise awareness and we come up with substantive and policy action that could help bridge the gap in disparities and in inequities that has plagued this region for a long time.
Thank you very much. Dr. Michael, how about the one component of your message that you want everybody to take away with at the end of today?
The one component that I would leave the community with is we all want change. We all want to feel better. We all want better healthcare, but it's our job as physicians to be responsible educators to empower patients to take charge. The culture and the patients have to take charge and responsibility of their own healthcare, and we're here to do that for them. So patients have to be alert, they have to be educated so they can take charge and so they can pave the way for the next generation so we can change culture together and change the system.
Thank you very much. You know, Boston Scientific is committed to this as well. We've got a Close the Gap initiative that's been going on for many years and has just gotten more enthusiastic over the past year. We are really working on diminishing and alleviating healthcare disparities. And as you could tell from these panelists, we're going to get into that very closely. Now, Dr. Michael, to drive this home, you have a patient story to tell us about. Would you please?
We sure do. We all encounter some very motivational and exciting patients in our practice. And many times we just are dying to show people what their message is. And many times it's much better and much more motivational than the physicians, because if we actually listen to the patients, they tell us the solutions. But when a patient takes charge and then actually becomes a patient educator and motivator with you as part of your practice, that's empowering. So I thought she would be a great story. Ms. Jackson encountered sudden encounter with coronary artery disease with a heart attack. And then 4 years later, she found herself facing amputation. And nobody ever told her that because of her risk factors, she could lose a limb. Her story is remarkable, and she became an immediate advocate for the disease, but not by going online or social media, by actually changing her home, changing her family, teaching them how to eat, and going straight to the Black community to tell them what matters and what they need to do to affect change. So she's really a remarkable person and very motivational, and she'd love to share her story with you guys. Thank you for the opportunity.
I'm Dr. Paul Michael, and I'm here with the lovely Charmaine Jackson, and she has something to say.
Dr. Michael, first, thank you for your time and having me.
My pleasure.
I just wanted to say that I had to be rushed to the hospital. Had to be rushed to the hospital through the ambulance. I couldn't walk because I couldn't feel my legs. They locked up and numb and tingling, but it was outside of the ordinary of regular sciatica. So once I went to the emergency room, they sent me home with pain meds.
But thank God you ended up coming back and meeting a vascular surgery team.
Yes.
Who ended up sending you to the limb preservation team. Yes. Because
I was in jeopardy of losing my left leg.
How did that make you feel?
Made me feel very scared and frightened, very overwhelmed.
And did you remember family members that had amputations?
Yes, my grandfather, my uncle, and they both lost their limbs.
And you have Cherokee, Native American, you have African American, obviously, Irish. And you've had multiple people have amputations and limb loss in your family. Yes. What was your first experience with cardiovascular disease?
Cardiovascular disease at age 49, I was diagnosed with rheumatic heart disease. My grandmother had angina.
And you ended up getting a heart stent.
I had ended up getting 2 stents in the valve.
And 4 years later, you were facing a possible amputation.
And facing a possible amputation.
So obviously now you're not facing amputation.
No,
much
thanks
happier.
to you. Thank you so much. And your
thanks to our wonderful team. But how's your life different now?
My life is different. I can walk, I can dance, I can work part-time, resume some daily normalization in my life to where I couldn't.
I'll never forget when you came into the office after, and you tricked me, you brought your cane.
Yes.
And you put it in the corner.
Yes.
And you didn't need it anymore, and you showed me that you could twerk.
Yes, I could twerk.
So what do you want to say to the people out there about what they can do to educate themselves?
Know your family medical history, stay informed, be aware, and share it with your family to change to pave the way to make a difference for our future.
Absolutely. Thank you so much, Ms. Jackson.
Thank you for
That's
having
amazing.
me, Doctor.
You're amazing.
Thank you. You're amazing.
Well, that's quite a story. So Dr. Michael, tell our audience, just explain to us, what is this thing called PAD or peripheral artery disease?
So peripheral artery disease is essentially an advanced form of blockages in arteries that supply blood flow to the entire body. Specifically here, we're talking about the arteries that feed the legs. So essentially in normal vessels, flow is like water pipes feeding a garden. If those water pipes are blocked up, then the garden starts to feel the pain. So the grass goes from yellow to brown. And when the grass is going from brown to black, that's the area that we work in called critical limb ischemia. So we have a very small amount of time to rescue these legs before we eventually can lose them. And we can't go to Home Depot and buy a new leg. You can do that with grass, but when you're facing amputation that's preventable, then we have to do something about it. And that's essentially how peripheral arterial disease leads into this disease called critical limb ischemia, which unfortunately is not defined well enough. Because you can go from having no pain at all to presenting with an ulcer, normally through diabetes, and all of a sudden you're being told you need an amputation. So the disease has to be understood at a community level, as simple as blocked vessels caused by things that we do to ourselves and genetic factors that we get from our family, because we can prevent this problem, which leads to amputation. I think it's important to understand it that way, Dr. Jeff.
Perfect, thank you. And Dr. Fakaridi, so why does this blockage happen? What makes somebody more likely to get this?
Well, it's a combination of factors. One, when you have peripheral arterial disease, you have to understand that it's part of a family of conditions called cardiovascular disease, which is the #1 killer of most Americans. And when you have atherosclerosis, which is the buildup of plaque, cholesterol, and calcium, the one thing you have to recognize is that as we age, that process gets accelerated. But there are also other risk factors and other behaviors that accelerate this process. So if you're a diabetic, or if you have high blood pressure, high cholesterol, if you're obese or you have kidney disease, that process is accelerated. If you have nicotine exposure, or if you use nicotine or you smoke it, you dip, chew nicotine, that process is accelerated. And it determines the extent of ischemia, which is the extent of blockages that you have, as Dr. Michael has explained, but also it also determines at what stage do we have to identify the level of disease and treat it at that level before it progresses to what we call end stage, which is called critical limb ischemia or threatening limb ischemia. And for those patients, unfortunately, rather than offer limb preserving strategies, amputation becomes the first strategy that is offered to the majority of patients, particularly those of color and those who live in low socioeconomic communities.
So let me just see if I have this one thing straight. I can understand, looking at this picture, that diseased vessel can't get blood to the foot. And if it gets really bad or people wait too long to get help, they could lose their leg. But I understand that people die more often because of peripheral artery disease. Is that true?
That is true. Majority of these patients who have peripheral arterial disease, if you think of the body as a whole, this process that occurs in your lower extremities also occurs in the heart, and it occurs in blood vessels to the neck. So these patients will subsequently have adverse outcomes or die from heart attacks and strokes. And if you look at the prevalence of heart attacks, strokes, and amputation, especially in the African American population, or Native American population, and in our Latinx population, those numbers are disproportionately higher, not because they only have the high risk factors or high prevalence of risk factors with atherosclerosis, but also they're least likely to be identified early on, and they're least likely to be offered life-preserving strategies to prevent adverse outcomes.
Now, Dr. Hawkins-Taylor, I heard from Dr. Michael and Dr. Fakaridi that older people are more likely to get this. People with diabetes are more likely to get this. The Black population is much more prone to risk from bad outcomes from PAD. So how does that sync with the research that you were doing?
Well, I've seen what they're talking about all my life. I was born and raised in the South in Shreveport, Louisiana. And, you just have to walk down the street to see the evidence of what they're talking about. The disparity, the inequities, the lost limbs. And I decided that it would be interesting to understand how you live before this happens. And, just thinking about someone on the edge of, on the financial brink, on the social brink, on the family brink, and how you cope with not only having the disease, but trying to keep from losing a limb. My grandmother, who's always the star of my research, I like to say, was the reason I took an interest in this. She's a longtime diabetic, and she maintained it very well for a long time, but as she aged, she started to get a little callous about management. And she and her sister sat down probably 10, 15 years ago and decided that they needed to help each other age. And in doing so, they needed to help each other manage their disease states. And combined, they have the cadre of diseases that are pretty typical for Black females. They all have heart disease. 2 of the 4 have diabetes. 2 of the 4 have peripheral artery disease. My grandmother was at risk of losing a limb, but had the wonderful physician to offer to do the things that needed to be done to save her limb. And so she can talk about that now, and her sisters, and she can think about how to help each other cope, and then they can advocate for others, and they could be an example of how to advocate. And I was thinking of this in terms of housing, and how many African Americans end up in poorly designed, poorly run nursing homes, and none of this is captured, none of this is taken care of. And so this shared housing environment that my grandma and her sisters have created was interesting to me, because they have organized this environment where they can care for each other. There's a circle of care and this duality in care where they're both receiver and giver of care, and they're organizing medications and going to doctor's visits, taking one to dialysis, and doing all these things to, number one, avoid these poorer exacerbated outcomes, and number 2, avoid the depression and the social things that come along with growing alone with all of these comorbid conditions.
Wow. So first of all, it's great to know that you're working on this, and obviously your research is going to have a dramatic impact. Now, Dr. Michael, I have learned in my career that some very simple things can truly save limbs and prevent all of the complications you're talking about. For example, if people that were at real risk, older Black patients with diabetes, knew that every day somebody needed to examine their feet, between the toes, on the heels of their feet, that just looking for telltale signs could catch a problem long before it leads to a risk of losing a limb. Is that true, and has that been your experience?
That's absolutely true, and it's so true that it's part of the guideline medicine, but we need to make things simpler than guidelines. So the reason why checking feet is so vital and so important is because that is the start of a cascade of events that leads to ulcer formation. And if you're able to pick up on calluses in diabetic patients, if you're able to find ulcers, and the reason why we're looking, and the family has to look, even schools have to look, dialysis centers have to look, is because these poor diabetic patients and patients with advanced peripheral arterial disease cannot feel their feet. So imagine driving a vehicle on the highway and you cannot feel the road and you cannot feel the tires. What ends up happening is the car ends up banging into the walls of the highway, having no idea that it's off alignment. And that leads to structural damage of the foot. And if there's no gas in the vehicle, meaning no blood flow going to the foot, then that car is going to be on fire and get in a really bad accident. And unfortunately, it ends up in a total loss, which is an amputation. Another interesting thing to point out is we're focusing on older patients, but we have another pandemic going on in the world. That's diabetes. So the combination of diabetes with obesity, which our Western society unfortunately promotes, leads to younger patients having more worse off diabetes. And so if that's happening, then we have to be open and admit the tough fact that we're going to be facing more amputations, which is why having this conversation is so important at the population and cultural level.
Now, Dr. Fakaridi, I've heard you mention something that's really a curious concept. I'd love you to tell me about this. What is the amputation lottery in America?
Well, thank you. I did not realize until I moved here to Mississippi that there are regional variations in terms of care, but also in terms of distribution of the disease when it comes to the different stages of peripheral arterial disease. If you look at the map of America prior to the Civil War, you can tell that during the slavery years, a lot of African Americans were in the South. Now, if you look at the map of the South, which I call the Black census scope, and you overlap that and look at the Medicare rates of amputations, the highest rates of amputations are found in that population in the South. And then let's put another layer to that. If you look at the lowest number of revascularizations in terms of the number of limb preserving procedures that are done in the United States, the lowest number of procedures are done in that population. And if you look at the rates of amputation, the highest amputation rates also result from that population. This could be said for every other cardiovascular disease. So where you live will determine if you get amputated. Your skin color, if you're Black, you're 3 times more likely than your white counterpart to get an amputation. In certain regions, that number is as high as 28, especially if you have diabetes, as Dr. Michael mentioned. Also, your insurance status. So if you're a Medicaid or Medicare uninsured patient, higher chances of getting an amputation compared to someone who's a commercial insured patient. And then lastly, it all depends also on your social determinants of health structure, right? And if you look at typically low socioeconomic African-American populations, which attempts to address this elusive social determinants of health structure for years has been something that we as a community and as a society, in terms of the medical society, we need to focus more efforts, just as Dr. Hawkins is doing, in terms of addressing the core issues. Because once you address the economic inequities, education inequities, and the low health literacy rates in these communities, and you address access to quality, not just access to care, but quality care, and you address some of the systemic and systematic structural inequities that exist in terms of governors and policies, then that also yields what we call the Amputation Lottery of America. And unfortunately, it disproportionately affects communities of color.
And this is a lottery you don't want to win in any way.
No, you don't. No, you don't. And the one thing that I would say in terms of awareness, the U.S. Preventative Service Task Force is basically the governing body of majority of primary care providers and family care providers, who are the first line of contact. So your first line of contact will also determine your amputation rate. And why do I say that? If they are not incentivized, or if they're not told that, yeah, you need to screen these certain at-risk populations, all the risk factors that we've mentioned today, and they don't agree that these patients are at highest risk of amputations, then the primary care providers will fail to screen these patients early on. Both my parents are diabetics, and today there's nothing in their governing structure that says my parents, who were diabetics in the 50s and early 60s, need to be screened with their socks off and pulses checked and have an ankle brachial index exam, so that they can get screened not only to identify PAD, but to identify the early causes of the leading cause of death, which is cardiovascular disease in the heart, and also to prevent preventable strokes. That's why that's important.
Powerful. So let's go to the next slide, please. And as we're looking at the information on this next slide, Dr. Hawkins-Taylor, give me a sense. You've already given us a really personal view as to why you are so passionate about this. But let me just get a sense, if you could give us an idea of what are the real emotional, clinical, and human impacts of advanced peripheral artery disease and limb loss?
Well, the emotional And social impact is really largely around not being able to care for your family and having to have alternatives to survive, having to make new plans for how to live post losing a limb. So we really want to get to the point of avoiding that process and stop that in its tracks. But financially, what jobs can you take? What work can you do? How can you navigate? How mobile you can be? All of these things are impacted. How you're perceived by society. It's all encompassing. And when you're living with diabetes, you're already living with the idea of having to monitor and do the things to manage the condition. You don't want to add another component to that. So financially, it's about maintaining a societal livelihood, maintaining an existence in the world that's worthwhile. And once that limb is gone, and once we've gotten to the point of not being able to be active in society, that puts us at a loss, that we're depressed, we're a shell of a human being at that point. And that's the part we want to avoid.
I think this slide, along with what you just said, is enough for anybody listening to want to do something to change the way things are. We already said that the risk of a Black man or woman developing peripheral artery disease is almost twice that of the white population. That almost 50% of people who lose a limb due to peripheral artery disease are dead 2 years later. I mean, this is a death sentence worse than most cancers. That peripheral artery disease is the #1 cause of amputations in the Black population. And hold on to your hats here. A diabetic patient undergoes an amputation every 30 seconds. If those things with what you just heard from our panelists doesn't get you to want to jump up out of your chair and help to change this, nothing will. Let's go to the next slide. As we think about some of the biggest challenges that we're facing, this is not a new problem. You can see here all of these stories from the 1800s all the way through what COVID has uncovered about healthcare disparities in America. I mean, these are things that we just cannot ignore any further. And so I would just ask my colleagues here, let's start with Dr. Michael. One of the ways that we can change this is to learn more about how early intervention and specific therapies can save limbs in the disadvantaged Black population. And why hasn't that happened? Why is it that so few high-risk Black patients are actually included in clinical trials of latest technologies?
Great question. So I'm actually going to paraphrase Booker T here, but he prophesied that this would happen. So that's why he created community disease action educational programs, because he knew that if neighbors and preachers and friends and parents weren't educating each other on healthcare, how to eat, how to live, then the healthcare system was not going to be their parent and take care of them. So if they didn't take care of themselves, then healthcare delivery would not be able to take care of them. So he was even consulted on by the US government. And the way they set up their system was with what Dr. Shamika Hawkins was saying, a sense of community. And if you have that connection with the sense of community, then you're tied into everything that works. When you're disconnected from that community, then you need education. We're at the point now, because of COVID, where we have to learn how to reconnect with each other. So we have to educate, we have to advocate. And that's a call to responsibility, which leads to what we're doing right now, which is a discussion leading to action. And so the education has to happen at the community level, teaching kids how to eat, how to fight diabetes, how to get sugar out of the system, because we're doing it to ourselves. And most of this disease process, which leads to the horrific amputation, which shatters the community, but not the actual person. There's still a person in there, and they can even advocate. to be able to say, this doesn't have to happen to you. So let's do something about it together. And I think that's why you see the people that are fighting amputation and dedicate their careers to it, they absolutely take it seriously because they know what it means. They see these people die. They know what it means to go to a dialysis center and not see somebody in a chair. And it's real. And unfortunately, the data doesn't reflect that because these are patients that never make it in the trials. So who's going to give us that data? It has to come from patients. And the way we get it is we go and talk to them. We find out what's going on in their home, who's going to be at higher risk of getting their leg cut off. And then we can go to the government together as a community and say, this is what the people need because people matter. And if you care about people, then you have to care about their legs. Because if people can't walk, they can't feed their families, they can't go to the doctor, and they can't work. So if you want to know what a leg is worth, well, ask a loved one who's not going to be able to get taken care of. Ask an employer who won't have somebody show up to work. Ask an athlete who depends on that leg to be able to play. So if we start looking at it from a simplistic, real way and not overcomplicate it, then the patients with the risk factors facing amputation have to be included some way in the data so we can have meaningful information to affect change, to affect better medications, better therapies, and then legitimize this field called critical limb ischemia. But what it is amputation prevention, because we are sick and tired of listening to patients just tell you, I want to live. And what's the prescription for that? Well, it's what we're doing now. It's educating the community so there's more awareness of the impact of how bad this really is.
Dr. Fakaridi, you've taken care of thousands of patients at risk for or already having lost a limb in the Mississippi Delta. Tell us how this has impacted you, your inability to get patients to you sooner, trouble getting them into clinical trials. What have been the obstacles to those kinds of things in your practice?
Well, first, you have to understand that, the life expectancy of a male in Mississippi is the same number as the life expectancy of an average American in 1960. 1960. So you have to understand that historically, why there has been mistrust in our system dates back to eroded mistrust from trials like the Tuskegee study, right? And so when I walk into my community and I look and reflect everything that is both positive about that community, but also aspirational goals of that community, I can engender the trust of that community to facilitate care-seeking behavior, explain and educate them and their community navigators who are out there in the churches or in their, community forums to teach them about their risk factors and why we need to take a preventative approach, because we live in a region that cannot afford the cost that it takes to take care of themselves as an amputee. The average cost to take care of an amputee exceeds close to $150,000 to $200,000. The average income of a Mississippian is about $36,000 a year. That doesn't add up. And so how can I prevent your diabetes from progressing to a stage where you present with critical limb ischemia or end stage peripheral arterial disease, whereby the cost of PAD exceeds that of diabetes and cancer? So we have to teach them and educate them, inform them so they can be transformed and take a preventative approach. The second thing that we have to do is we have to look at how we conduct these trials and who the communicators are, who are the principal investigators. Out of all cardiovascular trials to date, only about 4% have included African Americans. We have a 15% population. Hispanics, 1%. Native Americans, non-existent. End-stage renal disease patients who are predominantly African American, excluded from majority of the trials. And so we have a systemic issue in play here that we have to address. So what are the pipelines? Well, 5% of doctors or physicians are African American. And 1% of those who look like me in terms of a Black interventional endovascular specialist, less than 1% in the country. So I need to go to middle schools, to high schools, to colleges, to medical schools, to allied professional schools, to educate that it is cool to become a Dr. Fakaridi. There are options that you can take to go into the health sciences. Our politicians have to come up with platforms where we can help educate and raise awareness on this issue. All stakeholders involved in terms of colleges and allied professional programs as well need to be involved, whereby we can come and inform that next generation as to what the trajectory holds for them if we continue at this rate in terms of our diabetes, obesity, which are the two most challenging risk factors, and then how we can infuse them into these communities and incentivize them so they can bridge that gap, because we are losing the cardiovascular workforce. It's an aging workforce. So we need to bring in a younger group to come in and become the trialists, the physicians, the community educators, the researchers, the nurses, the techs, and the multidisciplinary team needed to stop this pandemic.
Well, I can tell you, I can vouch for the fact that it's at least cool to know Dr. Fakaridi. So it will be easy for you to convince people it'll be cool to become Dr. Fakaridi. So in our last few minutes, Dr. Hawkins-Taylor, we've got an opportunity with this audience, people in government, policymakers, to have them think about what can they do to support change in this dreaded disease process. So Dr. Hawkins-Taylor, let me start with you. From your perspective, in the Louisiana, Shreveport area, what should these policymakers be thinking about?
They need to think about the fact that this is indeed an epidemic. We're dealing with an epidemic, and in public health, the way you deal with an epidemic is you look at all the resources available and you mobilize those resources. That means all hands on deck. And in doing that, they need to think about all of the individuals that need to be a part of this change process. The doctors who have overwhelmingly hectic and busy schedules can't do it alone. So who's available to fill the gap? And that's when I talk about and think about the pharmacist role. The pharmacists are very engaged with the patient. They are already, through collaborative practice, performing some of these patient assessment things. Why can't the ankle brachial index be a part of that role? So policymakers really need to think about the all hands on deck approach.
I love that. All hands on deck, for sure. Let's go to the next slide. And let me go to Dr. Michael. Tell us, when we think about all of the risk factors we've talked about, these signs and symptoms that we've covered so beautifully in this last period of time, and then as we advance to the next slide, Dr. Michael, what's the message from you in South Florida to policymakers, government officials, about what they can do starting today to change how this goes?
I think the people are speaking loud and clear. They want help. I think the healthcare delivery personnel, the physicians, the hospitals, the clinics, they're a cry for help with the amount of amputations that they're seeing. And now policymakers have to listen. If they care about the people, they have to listen, invest in resources, specifically into dedicated personnel, just like Dr. Fakaridi was saying, critical limb ischemia, amputation prevention teams who just understand this. This is what they live and breathe day in, day out, who know they can salvage limbs. And if these are deployed with support, then we can affect change for real cost-effective healthcare delivery and save lives.
And Dr. Fakaridi, you gave us a lot of things to think about in your previous comment, your experiences in the Mississippi Delta. Tell us again, what are the things that you believe we need to see happen starting now so that we can say proudly in the not too distant future that the life expectancy of a Mississippi Black man is similar to the life expectancy of any man?
First thing we have to realize is, for that to happen, we have to address social determinants of health across all spectrum, and accept the fact that there's regional variability, not only in care, but identify those intractable barriers and attack them head on. So first, recruitment and retention of specialists to these regions should be incentivized. The second thing we need to do is that we need to raise awareness on PAD, and we need our public officials to help support that cause. The third thing is we need to promote and come up with policies that help identify at-risk patients, especially those of communities of color and low socioeconomic status. We cannot depend on societies that are waiting on research data, which is non-existent, to come up with policies to enforce that. We've already passed that sector. The next thing we need to do is to say, well, we have a pandemic of unnecessary and preventable amputations, and how can we identify, screen, and treat them early on in the disease process, just as we've done in the cancer world. We need to do the same in the PAD space. And we have to incentivize a multidisciplinary approach with our different colleagues and stakeholders so that we can come up with value-based outcomes. And lastly is to disincentivize reimbursements for people who choose to go with the option of treating patients with an amputation first strategy without utilizing all possible options as limb preservation strategies first. I think that's what we need to do. And my hat's off to the Congressional Black Caucus that has supported the PAD caucus, and hopefully they can help support that effort in the future.
Well, I have to tell you, I mean, I learned a lot from this discussion in such a short period of time. Just to summarize, PAD, this is artery blockage. If you find it in a leg, it's in your heart, it's in your arteries, in your neck. It's way more common in people who are diabetic, in people who smoke, in people who have poor diet, whose blood pressure and cholesterol is high. We heard the term diabesity. This is the combination of the other pandemic in the world besides COVID, diabetes and obesity with physical inactivity. Simple things, taking off your shoe and sock, having your family look between your toes, seeking medical care before it gets to be too late. And we as people who are standing up for the Black population to change the outcomes, this is our charge. We hope the policymakers hear what was said today. We have an opportunity to change the course of medical history by promoting good health, promoting the appropriate physician skills, incentivizing physicians to work with these underserved Black populations in regions of the country that have been grossly ignored. It is no longer acceptable. It is time. I want to thank Dr. Hawkins Taylor. What a superstar. We can't wait to hear more about your research. Dr. Michael, what you are doing in South Florida to really change the way we think about PAD and limb preservation, please keep up the good work. Dr. Fakaridi, the Mississippi Delta, a tough place to be. I give you so much credit for committing your careers to changing the lives of these people. Thank you for everything you're all doing. And with that, I'm going to allow us to look at one more video to tell the story.
We know how to treat the colds and the coughs. We know how to treat the bumps and the bruises, the cuts and fractures. But how do we treat, I can't afford a day off work to see a doctor? How do we treat, I've never had a doctor who speaks my language? How do we treat, I don't know how to connect with some of my patients? How do we treat, you're not listening? We can't treat what we cannot see. So we have to look closer and see what we're missing. People, patients, misdiagnosed, misunderstood, overlooked. These are the people left out of a system charged with helping them. And it's up to us to find them in our communities, in our relationships, in our data. We're meeting them where they are, discovering who they are. We're taking an honest look to understand their healthcare needs and delivering effective ways to reach them. We don't have all the answers, but together we can find a way to address the gaps in our healthcare system, to provide something better, to find more chances to save more lives. It won't be easy, but we can help make it right, because no one should be missed.
Thank you all very much.